Assalamualaikum warahmatullahi wabarakatuh. Okay, the title of this research is a virtual reality in treatment of spider phobia, a controlled study. Spider phobia is characteristically display persistent fear of spiders, immediate anxiety response upon exposure to a spider, and avoidance of spiders. In vivo exposure therapy has been used successfully with a wide range of phobias, including fear of spiders. Is considered to be treatment of choice for specific phobias. Many phobics are probably too afraid of confronting the feared object or situation to seek therapy. But studies showed that in comparison of willingness for treatment through in vivo exposure of virtual reality, results show people with phobias were more prone to choose VR. The present study is the first controlled study to test whether immersive VR exposure therapy is effective for treating spider phobia. They compared the effectiveness of VR exposure versus awaiting this condition. Okay, so the method used in this research in this study is, for the participants to join the study, they have to pass the following criteria. First, they meet the DSM-5 was criteria for a specific phobia animal type, which is spiders, according to the judgment of two clinical psychologists, which one of them blind to the condition of the study. The second, a minimum of 1 year duration of the phobia. The patient must not be able to remove the lid of a cage with a tarantula prior to treatment during the behavioral avoidance test. Fourth, have no other psychiatric problem in immediate need of treatment. And fifth, no current alcohol or drug dependence. And sixth, no severe physical illness. Most of the participants were female, and the mean reported duration of their fear was 21 years. The equipment used is a silicon graphics Octane MXC with Octane channel option, allowing stereo vision, coupled with 60 degree with a relatively wide field of view diagonal head mounted visual display. V8 helmet was used to create an immersive 3D interactive computer simulated environment. A polyhemous fast track position tracking system was used to measure the position of the user's head and hand position and the location of the virtual spider. The patient experienced Spider World, a modified version of Kitchen World 2. Anxiety diagnostic interviews Schedule 5 were used to ask the patient about the age of the DSM-5 specific phobia and animal type. The objective measure used in the study is the behavioral avoidance test BAT. In order for the patient to have achieved clinically significant improvement, they have to meet a certain criterion. The change from pre to post-treatment must be statistically significant. The procedure in the study starts with the pre-treatment assessment, where the participants were interviewed to determine if they meet the criteria for specific phobia, animal type spiders, using structured interview at these 5. The interviews were either taped, and another clinician blind to the study made a diagnosis. After that, the patient completed a questionnaire assessing their fear of spiders and were given the BAT. The participants who satisfied the entry criteria were randomly assigned to one of the two conditions, VR exposure group or waiting list group. Treatment consisted of a standardized exposure protocol delivered by two experienced clinical psychologists trained in experimental psychology. The treatment was composed of gradual exposure tasks. There was no fixed number of sessions, as the researchers established a criterion to define the completion of treatment. On the first session, participants saw a virtual spider in a virtual kitchen, approach as closely as they could using 3D wand to navigate through the virtual world. The goal was to come within arm reach of the virtual spider. During the following sessions, participants touched the virtual spider with their cyber hand with no tactile feedback. The virtual spider responded to being touched by feeling. Patients then picked up a virtual spider vase with their cyber hand. When they let go of the virtual vase, an animated spider with wriggly legs drifted to the floor of the virtual kitchen, accompanied by a brief sound effect from the movie Psycho. Participants repeated this task until they reported little anxiety. During the last therapy session, the participants were encouraged to touch the virtual spider image with their cyber hand. Participants reached out their cyber hand and physically touched the visual image of the wiggly leg virtual Guyana bird in tarantula. As the patients reached out with their cyber hand to explore the virtual spider, the real hand explored the toy spider attached to the stationary polyhemous position sensor. The virtual spider now felt furry and solid. Okay, the results showed that the score on the BAT showed that the interaction indicates that the groups differed in the amount of improvement. The VR exposure group showed greater improvement than the waiting list group. The results from anxiety during BART show that the interaction indicates that the VR treatment group showed significantly greater reduction in anxiety than control group. Independent assessor rating of phobic severity on the BART revealed that the VR treatment group showed significantly greater reduction than the waiting list group in the severity perceived by an independent assessor on the BART. Fear of spiders questionnaire showed that the interaction reveals that the amount of fear of spiders reduction was not the same for each group. The treatment group achieved greater improvement than the waiting list control group. Clinician rating of phobic severity analysis showed that the reduction in severity rated by the therapist was not the same for each group. The treatment group achieved greater improvement than the waiting list control group. Using both objective and subjective measures of fear, VR exposure with tactile augmentation significantly reduced fear and avoidance of spiders after an average of 4 1-hour VR therapy sessions. This is the first controlled study to demonstrate the effectiveness of exposure therapy for treatment of fear of spiders.
Next, I will present a research study about exposure-based treatment for cynophobia dog phobia. Exposure to fear-provoking object or situation is the central procedural element in behavioral treatment for specific phobia. Exposure techniques are very long, several dimensions, including gradation, duration, spacing, facilitation of mystery, and mode of exposure. Moreover, patient who refers to confront fearful situation in vivo may be prepared gradually for such exposure using imaginal procedure. Ideally, exposure-based treatment should be both powerful and convenient. Thus, researchers interested in pushing the envelope on phobia treatment are faced with the decision to either develop ways to make in vivo exposure more palatable to patients and more convenient for clinicians, or to develop more potent imaginary technique. Evidence for several suggest that imaginary exposure to fear-provoking cues may be enhanced through the inclusion of coping script into the imagery scene. Kazdin found that imaginary exposure was more effective in helping patients increase assertive behavior when they were instructed to imagine an assertive model. In the present study, we investigate the efficiency of a hybrid fear reduction technique that Kazdan have named active imaginal exposure. 82 participants meeting DSM-4 criteria for specific phobia animal type took part in the experiment. Participants were recruited from the undergraduate introductory psychology subject pool of the University of Texas of Austin, and from the Austin community. Selection of participants involved a two-stage screening process, beginning with a 12-item pre-testing questionnaire with assessed fear of dog on a scale of 0 to 4. Undergraduate participants respond to this questionnaire using an electronic format accessed via the internet. Potentially, participants who obtain a total score of 20 on the pre-testing questionnaire item 1 until 12 and responded yes to both of the above questions were invited to take part in a comprehensive face-to-face diagnosis interview. The specific phobia section of the ADIS has been found to have a relatively coefficient of 0.82. After completing this measure, participants underwent two consecutive behavioral approach tests with two different dogs. The purpose of each BAT was to measure multiple subjective, behavioral, and psychological reaction while encountering an actual dog. The procedure of the two BATs were identical, with the exception that different dogs were used in each BAT. A total of 9 different dogs were used in the study. Participant HR were collected using an ambulatory heart rate monitor. That unit consists of an electrode bell worn around the chest and a monitor worn on the wrist. The electrode bell transmits heart rate signal to the wrist receiver that display and store the participant heart rate data. During each bar, participants attempt to perform a 10-step hierarchy of increasingly challenged approach tasks, ranging from standing 10 feet from the door to putting one's hand in the door mouth. Participants would allow a maximum of 10 seconds to execute each task. Qualifying participants receive treatment on the day following the second stage of screening. Treatment consists of presenting the participant with a brief writing overview of specific behavior of dog that indicates safety or danger, a pop quiz to make sure the information was remembered, and 15 minutes of therapy directed exposure to the same dog using in part 1, and 15 minutes of exposure to a dog not encountered during the assessment. All conditions use identical procedure except for the mode of exposure and mode of coping. HR was collected throughout the 30 minutes of exposure. Treatment include of 13-step hierarchy of tasks that gradually increase the participant proximity to end contact with a dog. Participants perform each task repeatedly until their fear reduced to a level of 30 or less on a 0 to 100 scale. If a participant initially level of fear at any step was 30 or less, the participant was instructed to remain at the step for 10 seconds before advancing to the next step. At each step, participants in all conditions were instructed to categorize the dog behavior as threatening, submissive, or playful, according to the education presented yearly. The dog behavior reported by each participant in the in vivo exposure condition were used to yoke in the vivo condition to imaginary and active imaginary condition. In other words, the specific behavior reported by each participant in the vivo condition were used to construct the imagery script using in the imaginary exposure and active imaginary exposure condition. Consistent with treatment outcome data from study of other animal phobia and one case report of successful exposure treatment of dog phobia, Kasdan finding provide preliminary evidence that a dog presenting with a marked fear and avoidance of dog achieve a significant benefit from brief exposure-based treatment. As predicted, all three exposure conditions result in significant improvement with approximately 2/3 of all study participants showing marked improvement that was both statistically reliable and clinically meaningful. On the positive side, active imaginary exposure outperformed imaginary exposure alone at both and post-treatment and follow-up. Although the difference were not statistically significant, overall the inclusion of an active behavior coping procedure to imaginary exposure was well received by most study participants. This finding is consistent with findings from several recent empirical studies demonstrating that the destructive effect of safety behavior on fear reducing during exposure. It is important to note that this is the first investigation to examine the relationship between safety behavior use and treatment response to imaginal exposure.
Assalamualaikum warahmatullahi wabarakatuh. Next, I will present about a case study of behavioral assessment and treatment of insect phobia from Journal of Applied Behavior Analysis. So, firstly, what is phobia? Phobia is one subset of panic disorder in response to behavior, especially from this case study is insect phobia. A number of individuals will dodge or run away when seeing insects. Thus, To treat this insect phobia, conventional treatments that require repeated exposure to sequence stimuli or a special hierarchy resembling the cardinal members of the phobia class can be used. The approach to phobic stimuli will be focused at the time of assessment of behavior in the treatment used, but we must know the criteria diagnostic first, which is a decline in a person's performance or behavior. So, this will further strengthen the clinical analysis. Therefore, the main purpose of this study conducted was for the behavioral and treatment of insect phobia by using academic response as independent variable. Experimental subject was a 14-year-old male student named Mike. Mike was recommended by his school principals for this study because when there was the presence of insect in his classroom, Mike's academic performance was disrupted. Mike says that he finds it difficult to fully concentrate while completing his work when there is the presence of insects. In fact, Mike always been teased by his friends about this. Moreover, Mike is also aware of the insects that he himself afraid of, namely crickets, spiders, and ladybugs. Although phobic stimuli influence this behavior, this study focused primarily on academic performance as it was a major concern reported by his school principals. So, the dependent measure was Mike's work completion rate in the presence of crickets. The measurement for this case study, Mike is required to complete several mathematical questions in a room with a certain period of time. There were 3 conditions as a measurement in this study, but the difference was with the therapist telling Mike that the room had insects, whereas no insects were released, and the second condition was the opposite one. The third condition is that the room was placed with the insects. 2 treatments were used, namely graduated exposure and graduated exposure plus reinforcement. For graduated exposure, Mike will engage in 15 to 20 minutes of graduated exposure before each math test. This exercise covers the task hierarchy of behavioral approaches. There are 9 steps or hierarchies in this graduated exposure hierarchy. The first step is to start by holding a jar of crickets. The second step is to touch the crickets with the feet. The third step is to stand in a room that has a cricket with the eyes closed for 60 seconds. The next step is to collect the crickets using a piece of paper. The fifth step is to pick up the crickets by wearing gloves. The next step is holding crickets without wearing any glove for 20 seconds. The seventh step is to allow the crickets to walk on the legs of the pants. The eighth step is to allow the crickets to crawl on the back arm. The last step is to hold crickets with both hands for 20 seconds. Mike selects an initial exposure level for each session and continues to make the desired move until Mike refuses to proceed to the next step. Based on the steps that Mike had to do, Mike managed to finish up to the 6th step with the help of an assistant in the first session. However, Mike managed to do all the steps in the last session alone with the additional of the time period found in some steps. Next, for graduated exposure plus reinforcement, for this phase, it is almost the same as the previous phase, but was differentiates. It is that Mike will receive a token for each math test that have done correctly. Finally, regarding the experimental design, a multi-element design was used to evaluate the effects of the 3 evaluation conditions. The A, B, BC, A, BC design was used to compare the effects of the experimental conditions. The baseline phase is Mike's accomplishment when the inside condition is on display. Next, for the results and discussions, the result of the study showed that Mike got a high score when he was in a condition that was said to be free of insects. For conditions where there are said to be insects, initially the score rate is low but the rate is increasing. The next condition, the presence of insight indicates a low proportionate result of the correct answer. Treatment data also showed no improvement in exposure conditions and an increase in the pattern or trend between the two exposures with phase consolidation. The reversal phase show a moderate decrease in scores, with the last two sessions resulting in a lower number of correct problems than a single session combined with its treatment. The things that are said are related to the design of the study. This thing lah. The results indicate the value of pre-treatment behavioral assessment for treating insect phobia. Although initially school principals reported decreased lesson as performance when there was the presence of insects, this problem could be overcome when treatment assessment were performed repeatedly, when repeated verbal stimuli were performed even in the absence of insects. In fact, the results also show that adaptive behavioral targeting occurs directly by phobic stimuli. Besides, the result also showed that the tests might receive from his peers decreased after the end of the experiment because Mike had already succeeded or was able to remove the spider by his own using tissue. Next, for reward programs through token giving, it relies on adaptive responses that are sometimes required to overcome negative reinforcement that is assumed to be avoidance or elimination. Furthermore, for some of the issues that can be discussed in this study are related to the difference of mathematical calculations in the second policy phase is much higher than the first policy phase. This may be due to repeated training and exposure to insects. The second issue is related to the experimental design that does not take into the direct comparison of BBC between the two treatment components. The last issue is related to generalizations, that is about might probably making generalizations to all the insects that might fierce, so that maladaptive behavior is triggered. That's all from me. Thank you.
Assalamualaikum warahmatullahi wabarakatuh. Okay, the next article. Chocking phobia is a fear of anxiety about a specific object or situation. As such, this phobia disabling condition that results in fear and avoidance of swallowing food, fluids and pills. The core consequences of choking phobia are food refusal, which leads to malnutrition and in long term will bring serious damage to a child's vital organ. Eating can be seen as dangerous to the child. Okay, eye movement desensitization and reprocessing, EMDR, is a psychotherapy treatment that was originally designed to alleviate the distress associated with traumatic memories. In this study, age-modified EMDR is used. EMDR with play, storytelling, drawing, and the use of symbols offer preschool children with a meaningful and engaging way to participate in therapy. Okay, so the objective of this study is to add literature on the application of EMDR for a preschool child with a choking phobia. Okay, this study is using a quantitative single case study design to examine the efficacy of early intervention EMDR following an incident of choking on a fishbowl. Okay. For the 4-year-old client who did not meet the criteria in DSM-specific phobia, the researchers used an age-adapted standard EMDR protocol. Data of the study is obtained from the carrier, child, and session, including therapy session notes and reflective notes. Observation and child drawings. Data was explored notably, including assessing validity and standard protocol adherence. The subject in this research is the 4-year-old that was written as Sarah in the report. Sarah is normally a happy and healthy child until one day the incident of choking on fishbone when they were having lunch with the family. Okay, Okay, the treatment started 2 weeks after the choking episode. The standard EMDR protocol was adapted for her age using drawings, storytelling and playing with clay. 2 90-minute sessions were conducted with the client. The first session is used to build trust, explore the level of Sarah's traumatization, and teach Sarah the regulatory techniques. The story was constructed with the mother from what was reported about Sarah's experience during the incident, her current positive experience from everyday family life where she is loved and cared for, and ways and ideas of how to overcome anxiety in the future. One 90-minute standard EMDR protocol session with the mother was conducted in order to eliminate her emotional arousal about the incident and to make her more able to participate in Sarah's session. For the first session with Sarah, the main objective of the session is to become acquainted and discover the most frightening picture, install resources and investigate the width of her food refuser and prepare for the storytelling. The session was conducted in her aunt's apartment because she felt calm and safe there. The first session gives opportunity for Sarah to explain what happened to her. She got the idea that the food is dangerous because of the pain in her throat and inability to breathe normally she experienced during choking incident. Sarah rated the level of scariness she experienced was very high. Sarah during that time had admiration with the cartoon character Viking Princess. So the researcher took this as an opportunity to install resources by tapping her palms and saying that she is brave as the Viking princess. Other things to be noted, Sarah's food refuser had expanded to talk about the food, touch food, and even try to look at the food every time the food was the topic. Sarah started to regress and diverted attention to something else. Then the researcher used clay and imaginary game to show how food are not dangerous. During the game of touching food, salami, positive cognitions and continuous remark of food are not dangerous are installed by tapping her palms. The session lasted 90 minutes and they stopped when Sarah gets tired. Sarah was receptive during the session. After the session, the researcher conducted a psychoeducation interview with the mother, suggesting to her to play with the food and stop being obsessed with feeding Sarah. The family agreed to just let Sarah freely choose when she wants to eat and play imaginative games with food and about food. Okay, so the second session was conducted on Saturday. During the storytelling, when the parts with traumatic memories, Sarah was frozen, not moving at all, while the parts with happiness, she jiggled a lot, and her mother had to change her way of tapping. After the storytelling ended, Sarah continued to tell the same story but with different characters. Her mother continued tapping her while she was talking about successful coping. She drew the best part of the story when the princess overcame her fears and started to eat because she is brave while installing positive cognition. In one moment when Sarah was looking at the drawings and imagining the scene, she stopped her mother from tapping her because she said she couldn't see the picture in her head. It was clear the processing was really happening. Sarah was also told a story about a magical touch a princess used to overcome her fears. When Sarah feels afraid and cannot do something, just close her eyes and think of how brave she is and tap herself. The session lasted longer because Sarah was enthusiastic and wanted to play more, so the researcher decided to do more resources and they played with clay. They made a container with a snake inside and pink padlock on it, encouraging Sarah to put all her fears, bad thoughts and feeling inside the container. She started to make all kinds of shape with the clay to put into while the tapping still occurred to install positive feeling inside her body. The session lasted more than 90 minutes and by the end of the session her level of scare toward the food has fully dropped. After the 2 sessions, one of reprocessing, Sarah started to eat normally. The day after the second session, Sarah started to eat her favorite crunchy cookies with milk and cheese pie, and after that she started to eat normally all types of food. Her mother reported she had become her usual self, joyful, energetic and positive again. At the follow-up interview with her mother 3 months after the last session, improvement was maintained. Okay, from this study case, it is proven how an age-adapted standard EMDR protocol can efficiently resolve dysfunctional symptomatology within 1 month of its occurrence. This study also proved that EMDR can also be effective in resolving trauma-based phobia other than it used as the psychotherapy for resolving traumatic memories from our past. EMDR provoke chains of associations and adequate processing of relevant childhood memories and related affective materials. Early intervention is at the advantage for stopping later complication, reduce the suffering and risk of developing later serious psychopathological problems. Thank you.
Chocking phobia is one of those behaviors that the condition cannot control. There are also studies where the elimination or avoidance of swallowing food, drink, or any liquid as well as any form of pills. This condition also results in weight loss. As such, patients with this chocking phobia do not dare to eat alone because fear that no one will help them if the condition occurs. In fact, this chocking phobia can occur suddenly after several episodes of choking have occurred. The prevalence for women is higher than for men. However, this chocking phobia is comorbid with other psychopathologies. For example, when the choking phobic behavior occurs, panic or stress disorder can also occur. There are various types of treatments performed on patients with this chocking phobia. However, for this case study, eye movement desensitization and reprocessing (EMDR) was chosen to be used. The patient will be visually exposed to the traumatic memory component with the production of a rhythmic set of eye movements, hand typing, or hearing produced. Where there are external stimuli inserted, negative memories will be processed and assimilated emotionally. Thus, since patients with this chocking phobia are associated with anxiety with a traumatic experience, the likelihood of EMDR may help treat this uncontrollable condition. The subject for this case study was named Nancy, who suffered from panic disorder with agoraphobia versus extreme choking phobia. Nancy's condition occurred because of her past experience due to the negligence of the hospital leaving an object in her body while undergoing jaw surgery. Even though the object had been successfully removed, Nancy still felt there was an object in her throat. Therefore, the subject is suitable for this case study. There are several evaluations done before starting treatment. Among the assessment taken were symptom checklist 90 reverse, dental anxiety scale, and subjective unit of disturbance scale. Each of these assessments was taken continuously after treatment. Before beginning treatment with the use of EMDR, subject was instructed to select a negative condition describe her past experiences traumatic experiences. These negative beliefs will be replaced with positive beliefs of thought, positive cognition (PC) during the treatment. The first treatment was carried out by asking the patient to recall a traumatic event to the mind along with the NC. Patient was also asked to observe the therapist's finger movement while presenting the image or feeling of the NC earlier. Rest is also given between each series of eye movements (SEMS) as the patient explains what is present during the treatment. No interpretation was taken. Next, new SEMS were conducted with more appropriate variations and changes of focus. Throughout the first treatment session, pictures and physical senses followed each other in succession. However, suddenly a panic attack is present on the patient and the patient asked to stop treatment. After taking into account several aspects, the first treatment was discontinued. This is because the patient thinks too much about the traumatic event so that she cannot control her condition from panic attacks. The next session, the patient still agreed to continue treatment. So treatment is continued by changing the protocol phase by installation of fostering the presence of PC until the credibility for this PC is high by continuing SEMS. Also, as part of the phobia protocol, patients was asked to imagine herself in the future while playing a video recording of the session without causing an anxiety. Each disruptive aspect of the process is considered a separate written target. Video recording continues until there is no interruption. For the results and discussion, the response from the dentist was taken as a result for the decision. This is because before seeking treatment with EMDR, the patient experiences a phobia to see a dentist for fear of her choking phobia occurring. However, after receiving treatment, patient is more confident to see a dentist and appointment session become easier. Nancy also managed to swallow food normally after treatment. SCL 90R evaluation was also taken on patients 1 week after treatment. As the result, her score was no longer higher at 125 compared to before receiving treatment 196. In fact, the score was also decreased after the follow-up appointments. As for the DAS score as well, there was a change in the score from 20 before receiving treatment and decreased to a score of 5 after 15 months of treatment given. In fact, problems related to avoidance reactions or fear of choking were not reported a month and a half after treatment. Next, there are a few things to discuss. Among them is about the repetitive hand movements by the therapist taken into account in this treatment. This method is said to be less clear as to its purpose. Exposure to thoughts of traumatic event is one component of EMDR. In addition, the total exposure time to the treatment of choking phobia of patients was less than 5 minutes per session. According to Champlin and Levin 1980, based on from the article, short periods of exposure to traumatic items are considered insufficient. Overall, this use of EMDR is effective against certain phobias only. This is because there are a number of doctors who report good results with the use of EMDR as a treatment for phobia, but there are also a number who do not state its effectiveness. In fact, say they need to make improvement to their patients. Thank you.
Next, I will present a choking phobia. Choking phobia is characterized by the fear and avoidance of swallowing food, fluids or pill. The most common evaluation of treatment for choking phobia have consisted exclusively of in vivo exposure. In general, the collective literature on the treatment of choking phobia is characterized by uncontrolled and qualitative case study, and specifically the evidence for the efficacy of such treatment in children and adolescents is relatively lacking. To address this issue, they evaluate an exposure-based treatment of choking phobia in an adolescent girl. Patient description is: she stated that at the age of 5, she choked on food and needed the assistance of her father to clear her throat to allow breathing. At that time, she was unable to eat more solid food or drink beverage with ice. Moreover, she reported that she was embarrassed about her dietary restriction and was unable to enjoy common social activity involving food. In addition, she reported checking her mouth in the mirror frequently to look for good and chewy excessively while eating even the limited soft food that remained in her diet. In addition to the problem with food, the patient also reported frequent panic attacks during which she experienced such symptoms as palpitation, tachycardia, sweating, dyspnea, choking, paresthesis, and fear of dying. At the time of intake and throughout treatment and follow-up, the patient was not on any medication. On the basis of the initial assessment, a principal diagnosis of specific phobia, other type, was assigned. As additional assessment, she was asked to attempt to eat a specific amount of two favorite food, crunchy cheese curl and beef stick, each within a perceivable 2-minute time period. The two foods were also rated for the time to finish and number of bites taken. During each treatment session, the patient was asked to rate her anxiety for each of these 14 fear food. Then, the treatment grouping of food recording on the diary corresponding with the classification on the hierarchy. Foods eating could only be recorded under one group. Practice with the challenging foods progress from the easiest food on the hierarchy in the early session to the most difficult in the later session. At the conclusion of treatment at the 9 months follow-up, the time behavior test was repeated. This later subclinical diagnosis was assigned to describe occasional problematic generalized worry experienced by the patient. As in the post-treatment assessment, failure of her initial chocking phobia and panic disorder were absent. In addition, both the patient and her parent were asked to complete the questionnaire battery again at the post-treatment and at the 9 months follow-up. Because consumption was already at a reasonable high level during baseline for the first two groups, it was too difficult demonstrate an increase in consumption of this food following and the introduction of treatment. Although clearest result would emerge from the demonstration of specific change in the target food with no effect on the non-target foods, it was not possible to increase food intake in one target group without observing a natural compensatory decrease in the remaining groups. Conventionally, with the SUD data, there was some slight generalizing across series. Not surprising given that her fear was not of the food per se, but rather of choking in general, although this might suggest that the treatment duration could have been shortened. This was not necessarily the case. The problem was that there was actually a fifth category of food that was targeted during weeks 10 to 14. However, these data were not specifically observed from the beginning of the design because the patient did not discuss the problem with pill until late in the treatment. That is, when developing the initial list of fear foods, she avoided mentioning pills because the problem did not seem to her to be related to the phobia. The evidence suggests that a combination of exposure plus reinforcement reduced anxiety and increased the consumption of fear food over a period of 16 weeks, with some generalized to non-target syndrome of post-treatment.